طيب بسم الله الرحمن الرحيم. Good morning everyone. Today we are going to talk about bowel obstruction in children. This lecture will be in two parts. The first part will be about congenital bowel obstruction or neonatal bowel obstruction, and the second part will be in different lecture will be about acquired bowel obstruction. So classification of bowel obstruction can be by the site, whether this is proximal or distal, or mechanism of the obstruction, whether this is by extraluminal source or something outside the lumen that compressing it, or luminal, something within the bowel wall that's causing the obstruction, or intraluminal, which is something within the bowel lumen that's causing the obstruction. The third classification of bowel obstruction is by the onset, whether this is neonatal bowel obstruction or congenital bowel obstruction, which usually present in the first 2 to 3 days of life, or acquired bowel obstruction that happens later on. So neonatal or congenital bowel obstruction, which is going to be the topic of our presentation today, can be classified into atresia. Atresia can happen anywhere in luminal structure in the body, esophagus, pylorus, duodenal, jejunum, ileum, or colon, or meconium disease. Meconium disease is a group of disease that's caused by abnormal meconium causing bowel obstruction. Congenital volvulus, which is twist of the intestine that happens intrauterine or just prior to the baby exiting the abdominal cavity or the uterus. Small left colon syndrome or meconium plug syndrome, anorectal malformation, and Hirschsprung disease. On the other hand, acquired bowel obstruction, which I'm not going to talk about today, can be caused by adhesions, tumors, necrotizing enterocolitis, especially in preterm babies, pyloric stenosis, hernias, midgut volvulus or acquired volvulus, peritonitis such as perforated appendix, perforated Meckel's, and so on and so forth, missed Hirschsprung disease or intussusception. Let's take the first case. This is a newborn who's, as you can see in the picture, he's a trisomy 21 baby. The mother notices not tolerating feeds and has non-bilious vomiting or emesis. So having a newborn with vomiting, you should think about bowel obstruction, congenital bowel obstruction, and being a trisomy 21 baby, you have to think about duodenal pathology. If you look at this X-ray, you can see that there is two bubbles of gas in the peritoneal cavity, one in the stomach and the second one in the proximal part of the bowel, which is the duodenum. Another X-ray showing hugely distended stomach, huge gastric bubble, and duodenal bubble. This X-ray by itself is very much diagnostic of duodenal obstruction, duodenal atresia versus tight stenosis or duodenal web. Sometimes you can do upper GI contrast study, which usually not needed. You can see the contrast is filling the stomach, the pylorus, and hugely dilated duodenum, first and second part of the duodenum. In this picture, we can see a diagram of duodenal pathologies or duodenal obstruction pathologies. This is complete atresia. This is duodenal atresia with the fibrous band, or sometimes, actually more commonly, we see duodenal web, which is a mucosal web that's occluding the duodenum. Sometimes has a small opening, which work like a windstock deformity. In this pathology, you can see some distal gas, but the duodenum will be hugely dilated as well as the stomach. Management of duodenal atresia or duodenal stenosis or duodenal web is keeping the patient MBO, inserting NG to decompress the stomach, correct the dehydration, rule out other anomalies, which is which is can be done across all congenital anomalies, and then prepare the patient for surgery. Surgery involves doing a duodenostomy, which is creating anastomosis between the proximally dilated duodenum and the distally collapsed duodenum. Sometimes if the patient has duodenal stenosis or fibrous band, we do bypass duodenostomy. Typically the proximal part will be done longitudinal incision, and the distal part will be transverse to create what's so-called diamond shaped anastomosis, which keeps the lumen patent. Another scenario, 2 days old infant, abdominal distension, developed about 24 hours of life. Visible and palpable lobes on physical examination. Patient has bilious emesis. The stool or the meconium is pale gray and mucus appearing. The mother has history of polyhydramnios during her antenatal visits. So abdomen is distended, the baby is vomiting within 24 hours. This is suggestive of congenital bowel obstruction. We'll do an X-ray. As you can see, there is a few dilated lobes of small bowel. This is stomach, this is duodenum, and this is probably proximal jejunum. Another X-ray. You can see 3 bubbles: gastric bubble, duodenal bubble, and jejunal bubble. Another X-ray, you can see stomach, duodenum, and few dilated lobes of bowel. All these X-rays are suggestive of jejunal obstruction or jejunal atresia. Now, small bowel atresia is different than duodenal atresia. They can be classified into 4 types. Type 1, where there is only mucosal web including the lumen of the intestine. Type 2, there is a fibrous band connecting the 2 separate lumens, but the mesentery is intact. Type 3, the 2 side of the small bowel is separated, and the mesentery, there is defect in the mesentery, which can be type 3A and type 3B, where the distal part has a pil deformity, which is there is significant loss of the mesentery and the blood supply, where the blood supply of the small intestine is very much in the center, and the bowel is twisted around it. And type 4, where there is multiple atresia, called shish kebab kind of deformity. Now, whenever you have somebody with the suspected small bowel atresia, you want to check the colon as well. So once you have the diagnosis, you entertaining the diagnosis of a small bowel atresia, you have to do contrast enema. The enema will help you in 2 things. First of all, will rule out distal anomalies, and second thing, make the incision smaller, because you didn't need to mobilize the colon and check the colon. So if you decide to make anastomosis, then you know that the colon has no atresia, and you can repair the small bowel without worry having a distal bowel obstruction. Another picture of the small bowel atresia. This is type 1, which is mucosal web. Type 2, where there is fibrous band, intact mesentery. Type 3, where there is separate loops and defect in the mesentery. 3A, 3B, where there is Christmas tree, huge mesenteric defect. And type 4, where there is multiple atresia. This is intraoperative picture of small bowel atresia. You can see the proximal atretic segment is dilated and the distal is collapsed. Another picture, this kid has type 4 atresia. The proximal jejunum is atretic. Here there was mucosal web. This is another segment that's atretic. One more segment atretic here, and one more segment atretic here. So this is type 4 small bowel atresia. Third scenario, 3 days old male preterm, born at 36 weeks of gestation, presented with bilious emesis, significant abdominal distension, and he's failing to pass meconium. The mother has history of gestational diabetes. So again, he's only 3 days old, bilious emesis, abdomen distended. You should think about congenital bowel obstruction. Not only that, baby is not passing meconium, and maternal gestational diabetes is a hint for one pathology, which is we'll talk about later on. If you look at the X-ray, which should be the first investigation you perform, there is lots of dilated loops of small intestine, and the abdomen is distended, which is suggestive of distal small bowel or colonic obstruction, compared to the jejunal atresia, where there is only few dilated segments of small bowel. Here you can see many segments of small bowel bowel is dilated. So you start with contrast enema, and the contrast enema, what you can see, the left colon is small in caliber, and there is phallic defect, as you can see here. With the history of gestational diabetes, this is diagnostic of small left colon syndrome, or meconium plug syndrome. Usually the contrast enema, what you see right here, is diagnostic and therapeutic, because the baby will pass this thick base T meconium, and the bowel obstruction will resolve. Things that you should keep in mind with babies with small left colon syndrome: there is a possibility that this baby may have Hirschsprung disease, infant of diabetic mother, as we mentioned, maternal hypothyroidism or infant hypothyroidism, maternal use of narcotics, and cystic fibrosis. So you have to keep those in mind and do the necessary workup. So as we said, usually confirmed with enema. Plug typically pass spontaneously both the enema. Be aware of the association: cystic fibrosis 14%, Hirschsprung disease 10%, prematurity, maternal use of magnesium sulfate, sepsis, hypothyroidism, diabetes. Usually no further treatment is needed unless the symptoms persist or there is high suspicion of Hirschsprung disease. Then you should think about performing biopsy and doing the necessary workup for the cystic fibrosis. Another scenario: 2 days old male infant, marked abdominal distension, visible and palpable loops of small bowel and colon, dewy abdominal examination. Like when you examine the abdomen, you can feel as if there is a dough in the abdomen. The mother has history of polyhydramnios. So 2 days old, abdominal distension. All these are suggestive of bowel obstruction. The dewy sensation and the polyhydramnios is suggestive of something. We'll talk about it later on. You look at the X-ray. There is few dilated loops of small bowel and probably colon. I'm not sure, but this is suggestive of distal small bowel or colonic bowel obstruction. So you start with contrast enema. So you perform the contrast enema. You can see the left colon is normal in size. Actually, the whole colon is small in caliber, but there is no discrepancy between the rectum and the left colon and the transverse colon. And when the contrast goes into the small intestine here, you can see multiple filling defect in the terminal ileum. This is suggestive of meconium ileus, where the thick meconium is actually occluding the distal small bowel. So when the thick meconium reaches the distal ileum, it becomes stuck there and causing this distal small bowel obstruction. The proximal bowel will be dilated and the baby will have symptoms of vomiting. So meconium ileus can be treated non-operatively as well with the enema, contrast enema. Usually use diluted gastrografin, about 50% diluted, because the full strength of gastrografin is about 1900 milliosmol, and that's about 4 to 5 times the osmolality of the blood, which is 300. So it's quite dangerous to use the full strength. We use diluted gastrografin to prevent fluid shift and hypotension. The efficacy of diluted gastrografin is about 50 to 70%. It can be repeated up to 3 to 4 times. Sometimes you can mix it with N-acetylcysteine, which is mucomist, to break the bonding and the charges between the mucosa and the meconium. If the non-operative measures fails, then you rescue the patient with an operation, or if there is perforation, or if the patient is unstable. Causes cystic fibrosis, about 70% of patients with meconium ileus, Hirschsprung disease, maternal hypothyroidism, magnesium sulfate prenatally. Another scenario, 2 days old infant failing to pass meconium, abdomen distended, feeding intolerance, with bilious vomiting. So he's only 2 days. This is suggestive of congenital bowel obstruction, abdomen distended, bilious emesis, and these are suggestive of distal bowel obstruction. You do the X-ray, there is quite few dilated loops of small bowel, again suggestive of distal bowel obstruction, whether distal small bowel or colon. What to do next? We'll do contrast enema. When you do the contrast enema, have a look at the caliber of the rectum and the sigmoid colon. There is discrepancy between the two loops of bowel. Typically, the rectum has the widest diameter in the whole bowel. Having larger sigmoid diameter compared to rectum, this is suggestive of reversed rectosigmoid ratio, which is suggestive of Hirschsprung disease. Hirschsprung disease, we have another presentation devoted for Hirschsprung disease. You can go back to the channel and look at it. But anyway, this is normal colon, and this is Hirschsprung disease colon, where there is the distal bowel, the affected egg ganglionic segment is collapsed, and the proximal bowel is dilated. How to diagnose it? With the suction rectal biopsy. Another contrast enema showing a small caliber rectum and distal sigmoid with dilated proximal sigmoid. And then do the pull through once you confirm the diagnosis. Another scenario, 5 days old infant with marked abdominal distension, non-bilious emesis, feeding intolerance, failing to pass meconium. The baby has query or quote-unquote normal newborn exam in delivery, after delivery. So he's only 5 days old, abdomen distended, feeding intolerance, failing to pass meconium. So you have to think about congenital bowel obstruction in this kid. What to do next? You go and examine the patient. When you examine the patient, the baby has abnormal anus with a small, almost pinhole opening in the perineum. This is suggestive of imperforate anus with the rectoperineal fistula, and this is the reason why the baby has abdominal distension, because he's not able to clean or pass the normal bowel movement and deflate his colon. So it's very important to examine the baby completely and make sure he has no anomalies. Imperforate anus or any rectal malformation, we have another presentation devoted for this, so you can go back to the channel and have a look at it. It's typical workup. You have to do midline workup, bacterial association, echocardiogram, ultrasound, renal, spinal ultrasound, spinal x-ray to look for any spinal abnormalities. and examine the upper limbs and lower limbs looking for any limb anomalies. This is bone jackknife X-ray looking at the air filling the distal rectum. Just another scenario for very rare case. This is a fetal ultrasound at 20 weeks, so cystic abdominal mass. The delivery was uneventful. Baby has day 1 of life, has distended abdomen and not tolerating feeds. When you do the X-ray, the bowel is shifted to one side of the abdomen, suggestive of mass occupying lesion in the left side of the abdomen. Again, if you see at this X-ray, this is the stomach compressed by a cystic mass underneath. When you explore, has this cystic mass, which is a duplication cyst, which is another cause of congenital bowel obstruction. It's not very common, but can happen. So this will conclude our congenital bowel obstruction talk, and the next one will talk about acquired bowel obstruction. Thanks for listening. Take care.